Welcome, everybody, to this edition of the Pelvic Health Explorers interviews. I am beyond excited today, beyond excited. We've had such wonderful people on, but we have the absolute, what I consider pinnacle of pelvic health information, education, mentoring with Michelle Lyons from Ireland today with us. If you don't follow her on Facebook in her Facebook group, Global Physio, did I say it right? No.
Global Pelvic Physio.
Yeah.
There you go.
At least almost 3 times a week, if not more. She's got a brand new article out that she shares, and she shares the highlights and the information from it. So, if for no other reason, just join that group so you can get the latest and greatest in what's going on in public health research and in related research, which is what we're going to talk about today. But first, Michelle, tell everybody your story a little bit. I don't think people know the other
Okay.
side of Michelle. I think they know you and what you celebrate and how you show up in the world, but give us some fun things about the backstory.
So let me see. Potted history. I qualified as a physio over 30 years ago. And about 6 months after I qualified, I moved to the US to work in Connecticut and was there for a number of years and met my husband and we got married. So my husband is American. And then really started my career, initially in the US, and then we moved back to Ireland. And my focus was very much on sports medicine, and that's where I wanted to be. And, after we moved back, I got a job working with a really high level males football team. So we were doing training camps internationally, we're doing a lot of different sporting events. And I loved, running on the pitch and doing all of that. But then I got pregnant and I had my daughter. And that's when my career kind of took a detour because of my own obstetric misadventures. So lots of different things happened during that labor and delivery scenario and postpartum recovery that left me thinking there has to be a better way. So quick detour away from sports medicine, deep dive into pelvic health, primarily female pelvic health. And of course, like most of us started out, thinking about postnatal recovery and incontinence, and then kind of really embraced the whole concepts around pelvic pain because I could just see that this was a group of women that were not being well served at all. We were back in the States for a couple of years. I started teaching for Herman Wallace and really kind of, developed a depth of understanding about the complexity of pelvic health, first of all, but also why, as physios, we are just so well positioned to deliver what I think it truly means to have a biopsychosocial approach because we can
Mhm.
look at derm, we can look at musculoskeletal, we can look at pelvic, but we can look at the person that's attached to that pelvis as well. So, I think during the pandemic, while everybody else was making banana bread, I went back and I did a postgrad in health coaching and nutrition, which was kind of just to formalize the studying that I'd been doing myself over the years, and did another postgrad in business management in entrepreneurship, and then did another one in sexual health promotion and really just kind of adding to my toolbox teacher trainings and yoga and Pilates. I went to the University of Arizona and did some training in herbal medicine there because we can't just treat an isolated part of the body. Nothing happens in isolation in our bodies. And so I'm very greedy when it comes to knowledge like that. I used to be a big fiction reader. I don't read that much fiction anymore because there's so many exciting things happening within the world of pelvic health, of women's health in general, whether it's menopause or breast cancer or gynae cancer or GI. I have a job now that still makes me excited. I actually ended up kind of going back in a way to sports medicine because I'm working as part of the FIFA Female Athlete Project. But I also do some teaching for different organizations, like the European School of GI Oncology, and I'm a consultant with Bayer Pharmaceuticals with their endo and uterine pain forum. And then, I love going to conferences, so Pelvicon, CSM, ICS. It's a great time to be doing what we're doing, and I think the future looks really, really bright. I'm from an era where we used to have to go down into the basement library and pull out the drawers with all the little file cards on them and all the references. And now I can just pick up my phone and I can take a dive into PubMed or Google Scholar. It's an exciting time to be alive and to do what we're doing. And I'm probably more passionate now than I've ever been in my career.
100%. And if you don't know Michelle, I would love to spend a year in her house with her library. Whenever she's going to conferences or she's traveling or she's doing all of the wonderful things she's doing, you can find her at the local bookstore,
Yeah,
looking to
that's a
see
fair.
what
Yeah.
might be there, what she can uncover. She's always posting about it. It's like absolutely fantastic.
But it,
So
it could be drugs, Susan. It could be drugs, right? That's what I always say when I'm trying to struggle with weight allowances in suitcases at airports. This would be so much worse if it was drugs. I make no apologies for my book buying habits.
yes, exactly. It's your crack den.
It kind of is, yeah.
And that's okay. We all have our places and we all have the ways that we do things, but I love the exuberance and the excitement that remains because it does with me as well.
Yeah.
And with a lot of us that are still in the field, that are still doing and making differences in
Yeah.
any way that we can and contributing in so many ways. And you were like probably the number one contributor of
Oh.
information distribution and also the champion of clients' self-efficacy and
Hmm.
client empowerment. And we're going to talk a little bit about that today because we're going to dive into an issue very near and dear to everybody's heart, but especially yours as far as where you are right now, is
Yeah,
with sexual health. And
absolutely.
one of the things I want to just start with is like, why do we need to not just provide good education to clients, but what about the other medical colleagues that
Yeah.
we have? Kind of give us a little story here about your launch into some of your latest work in sexual health and what you're doing here.
Yeah. So, depending on which paper you're looking at, dyspareunia, which is probably the term that we're most common with, pain with sexual activity, and that can be before, during, or afterwards, affects anywhere from 3 to 47% of women worldwide. And honestly, I am unabashedly female centric because I just feel like women's health has been so far behind for so long. I acknowledge everybody has a pelvic floor, everybody deserves good pelvic health, but this is my passion and this is my experience. So, dyspareunia and or vaginismus, which is kind of under this umbrella of GPPPD or genitopelvic pain penetration disorder, to give it its rather unwieldy title now. It's such a common issue. But here's what's happening to a lot of the women that I'm seeing who are maybe going through menopause or going through cancer treatment, particularly, is that
Hmm.
they're trying to get their lives back on track. Maybe they've gone through cancer treatment, particularly, and they're starting, they're resuming work, they're resuming a semblance of normality again, but they're having pain with sex. And nobody is talking to them about it. And this is borne out in the literature as well. It's not just kind of anecdotal evidence that
Hmm.
whether it's genitourinary syndrome of menopause that's come about as a natural progression through this normal life stage, or it's GSM provoked by a hysterectomy with oophorectomy or by cancer treatment or premature ovarian insufficiency. And this is just one section of women that I'm talking to who are having sexual pain. Without fail, most of them are disappointed with the interactions and the conversations that they have had with their medical providers about sex. A, nobody has talked to them about it. And B, if they've been brave enough to bring it up with their doctors or surgeons or radiation oncologists or gynecologists, even or urologists, they're told, well, that's normal. It would be greedy to ask for more. Or my perennial nemesis, have a glass of wine and
Oh, yeah,
relax.
I was going to say the typical calm down, have a glass of wine, it'll be okay.
Oh, it
The
does
worst pandering ever.
just dry. It makes me crazy. It's so gaslighty, because it's like it's just because you're nervous or you're wound up. And honestly, it can take so little education sometimes to turn that ship around. And,
Hmm.
sexual function, it's on that foundational level of Maslow's hierarchy of needs. It's a basic human need, it's an ADL. But this is
Hmm.
where I think we can really shine because we have time with people and we can bring those interviewing skills and those, overview, being really psychologically informed, acknowledging that we know that at least 1 in 3 women have had some sort of sexual trauma or violence. And of course, that can be a big driver. But as you know, I did a post on Instagram a little while ago saying dyspareunia is not a diagnosis. And so we're in a great position to be able to just dive a little bit deeper into it. Is it because of low estrogen? Is it because of scar tissue? Is it because of a tendinopathy around your hip? Is it a previous traumatic event? And even, we know we've research going back to the late 70s at this point, probably before some of your listeners were even born, that shows that if we have one painful sexual encounter, then the brain and the pelvic floor start to anticipate pain with future sexual encounters. And so they're tensed up, bracing for impact. And of course, if muscles are tight and upregulated, there's no circulation getting through. So there's going to be no lubrication, there's going to be no clitoral erection, there's going to be no joy at all. And that really kind of sets me off down a path of being very emphatic that we want to move from sexual pain, whatever the driver is. And again, I think we can be really good detectives here, but moving beyond just tolerance and into sexual pleasure. Because there are four main types of female sexual dysfunction: orgasmic disorder, interest or libido, genitopelvic pain or penetration disorder, which is kind of an umbrella term for both vaginismus and dyspareunia, and then medication-induced hypoactive sexual disorder. And again, if you've got a trained eye and a trained detective's mind, you're going to be able to figure out, okay, so which of these four is the primary driver of her issues? And then, of course, like finding out what are her goals. Is it to have pain-free intercourse? Is it to be able to have a speculum exam? Is it to be able to insert a tampon? Is it to get pregnant? And so we leave all our judgment at the door. We are here to serve. Tell me what's important to you. Tell me what the problems are. Tell me what you'd like to be able to do if this pain wasn't here. And then we're going to work together and reverse engineer. We're going to put on our traditional physio hat first of all and do a complete screen of your spine, your hips, all that hip musculature, particularly your adductors, your abdominals, looking for any scar tissue restrictions, being on the lookout for any little sneaky signs of endometriosis along the way, because 1 in 9 women worldwide, and of course, pain with intercourse is one of the big cardinal signs there. But literally nose to toes approach, body and soul, and really getting very specific. So creating very much a bespoke plan for the person in front of you, bringing bringing a bit of nuance to it. So we're not talking about protocols here. We're talking about there are no recipes. It's all about just basically making it up as you go along, but with the patient at the center of the discussion. And so there's active listening, there's motivational interviewing, there's assessing readiness to change in terms of behavior
Mhm.
modifications. A lot of this can actually work really well even via telehealth. Because again, we're teaching people then, we're really promoting that element of self-efficacy. Because if you're coming to see me once a week and you're only doing dilator work, or as we're now starting to see them called vaginal trainers, which I think is a much better term for them, if you're only doing that once a week with me for an hour, what else is happening? So I want you to be continuously refreshing that sensory homunculus and re-establishing a friendly conversation between the brain, the nervous system, and your pelvis, and learning to be comfortable with yourself first before we actually even bring a partner into the conversation. So we have so many tools at our disposal. And what's lovely is we now have the evidence catching up to that practice as well. So we're kind of in that sweet spot.
Absolutely. And I love what you were saying about all of the detective work and looking at it. I call it the fascinated anthropologist.
Love
Without
it.
judgment, you're just like looking and what are all the pieces here? Because oftentimes it may not be the obvious and it may not be what you think it's going to be. Then, therefore, if you
Hmm.
eliminate all of that, like Sherlock Holmes, it's going to be something you didn't think of. And guess
Yeah.
who's going to give that information to you? The client. And the
Yes.
reason that we put the client in the center here is because they know more than they know. They are the
Yeah.
experts in their body, they're the experts in their life. They, if given the opportunity and the time to explore, they can tell you what's going on. So,
Yeah.
that whole idea of like, what do you think is happening?
Yeah.
What are
Exactly.
you concerned about? Like in your
Yeah.
heart of hearts, what are you mostly concerned about? And what do you want? Like, where do you want to go?
Yeah.
What do you
Yeah.
really, really want? And being able to add that piece in brings out that, like you talked about, the psychosocial piece, which is
Yeah.
they may not want what you think they want at all.
Or what you
Right?
think they should want.
Exactly. Yeah. Or even worse, yeah, putting your bias on top of it.
Yeah.
So pattern recognition goes only part of the way. And by doing this detective work, you're talking about like really doing a like, let's see what's going on here with your whole body movement piece and those types of things. And where are they in their life as far as like hormonal transitions? Let's talk a little bit
100%.
about hormonal transitions. You mentioned it for just a moment there with the post-cancer and some
Yeah.
of the other medical, what we like to call medically induced menopause, whether
Sure.
it's because of medications or because of radiation and chemo or whatever
Yeah. Or
it may be,
surgery. Yeah. Absolutely.
yanking the uterus and the ovaries out.
Yeah, for
Any
sure.
of
I
these.
mean, I really like when I'm talking about kind of women's health, female health in general, I like to kind of think about three distinct eras. In the menstrual era, so we're in our reproductive years, what could be driving sexual pain? Well, of course, the first thing we're going to think about is endometriosis. And here's a top tip for your listeners. And this was done by some research by Paul Young a couple of years ago, that if somebody has both superficial and deep dyspareunia, there's a really strong chance that it's endometriosis that's driving that. Because there was a tendency for quite a while to think, oh, superficial sexual pain, vulvodynia or provoked vestibulodynia, deeper pelvic pain, endo, because, endometriosis loves to grow in that recto-uterine pouch. So, the pain with deeper penetration, and that makes sense. But when you have both superficial and deep, that's also a big red flag for endometriosis. So we know that our hormones really drive everything. If we didn't have these rich roller coasters of hormonal activity, we'd be dead. But it's when they start to get a little bit out of balance. And I use the term with trepidation because balance to me almost implies like a static position. Whereas I think it's more like walking along a tight where we're all the time just kind of tweaking and adjusting and going with that ebb
Mhm.
and flow because again, we've got that lovely menstrual cycle that takes us up and down and in and out. But other hormonal drivers during that particular phase to think about might be, again, this comes back to good detective work, doesn't it? Did the pain start when you started a new type of oral contraceptive pill?
Mhm.
Now, it's super popular on a lot of social media sites to bash the pill. And
Mhm.
I think very unfairly because the pill has done more to give women reproductive freedom than I think any other advance over the past decades, past century. However, there are a proportion of people who do not respond well to it, and it can really mess up those androgen receptors. Those are the people for whom provoked vestibulodynia can become a really big issue. So the simplest thing to do, we talk about dietary irritants and, to check and see for sensitivity, we just take them out of the mix for a period of time and then we see what happens symptom wise. And oftentimes that can give us a good indication of what's happening in terms of oral contraceptive driven sexual dysfunction. So those would be the two kind of main ones that I would see during the reproductive years, those menstrual years. Pregnancy, again, we've got a lot of vascular changes going on within the pelvis. And so things like vulvar varicosities, but even just dynamic control of the body, particularly the pelvis, can be problematic. Changing body image often gets overlooked as well. I think that can be a big driver. So if we're seeing people with pelvic girdle pain during pregnancy, are we always asking them about their sexual health as
Right.
part of that? Because again, I feel like no is the answer generally when I ask this question to a class. But I suppose really it's in postpartum that we can see a lot of bio issues that can drive and then become psychosocial as well. So whether that's scarring from an episiotomy or a tear, whether it's pain from a C-section scar, because remember the suspensory ligament of the clitoris is attached up into the abdominal tissue. So that can cause problems. Of course, if she's breastfeeding or if she's postnatal and perimenopausal at the same time, she's either going to be dealing potentially with genital urinary syndrome of lactation or just that really slow or maybe no return to ovulation, menstruation. So estrogen is low. So we're looking at a lot of dryness, a lot of discomfort. And then we might throw in a few hot flashes just for extra fun as well, a bit of sleep disruption. And we know from research, people like Melissa Farmer back maybe 10 years ago has done some research on gender differences between pain and sexual dysfunction. And so a lot of her work was mouse-based, admittedly, but she found that female mice, when they're in pain, it really, really turns off their libido. That is
Mhm.
not true for male mice. They're fine. They'll just keep going, even if they're in pain. And Laurie Brotto has taken that on and like looking at human subjects when women have stress and anxiety, that turns their libido off. It can actually turn up the male libido. So we have to be aware that yes, there's sex differences, but there's also gender differences as well and kind of sociocultural images. But we throw in some body image, again, sleep deprivation, and the pressure to get your body back after baby,
Right. So the
and
changes
being
in what you're
touched
eating.
out.
Hmm.
Yeah, but you're completely touched out, aren't you? You've got a newborn to care for. Your body is not your own anymore. And so sometimes sex can be feel like the last thing. And then if you're not aroused enough and nobody's had the conversation with you about scar massage or even the judicious use of lubricants, it's going to hurt, which is going to make you less inclined to pursue it. And of course, then that can persist and turn into a huge problem relationally and can really have a lot of both physical and mental ripples on a person's life, on their physical health and their mental health. And then kind of taking that through then to perimenopause, again, hormones really roller coastering during that perimenopausal transition. So maybe from mid 30s onwards, we might be stressed, we might have some anxiety, some depression, some changing body image issues, but also, of course, the classic genitourinary syndrome of menopause. We've moved on from calling it vulvovaginal atrophy, and we've moved on, thankfully, from the even more delightful previous term, the senile vagina. You know, misogynistic medicine much, but anyway. Um, but it's not just about dryness or discomfort. It's about clitoral phimosis. It's about the disappearance of the labia minora. It's about the discomfort maybe in around her hips. We know that gluteal tendinopathy affects 1 in 4 women at perimenopause.
Hmm.
So again, this is where we can step in. We can zoom in and look at the issues in the tissues, but then take a step back and look and see, well, what's going on with her glutes, with her adductors? Has she had any abdominal surgery? Is she getting any sleep? We also see a spike in issues like IBS at this, menopausal transition as well. And I mean, if you're feeling bloated and constipated, that's a bit of a libido killer as well. So we've got libido, we've got intercourse itself, and then we have the ability to even, to have an orgasm because it's not about tolerance, it's about enjoyment. And so oftentimes at midlife, that's when we might be able to see some signs of pelvic venous disorders. If somebody's coming in with postcoital pain and that sense of heaviness or fullness, we can think,
Hmm.
could it be? And it's about that interplay of all the different systems and the person who's kind of driving the ship and what's going on in her life and what matters to her. So I think to be able to break it down into each of the component pieces, whether it's libido, intercourse itself, orgasm, and then where exactly are we having the problems? And let's really zoom and get quite specific with that. And then treatment is actually quite easy because then we
Yeah.
can reverse engineer it. And sometimes it's, I would say almost all pelvic health physio, 90% of it is education.
Hmm.
10% is maybe manual therapy and movement prescription. But most of
Hmm.
it is education, isn't it? I mean, and giving people the right tools for the job and putting them back into their bodies again. And just helping them realize that they're not the only ones because this can be so isolating and so embarrassing for people. And it's just to create a safe space to have these conversations. I think it's so vital.
Yeah, and just, the idea that they just feel like they have to live with it.
Yeah.
And they, and maybe they've even tried some things and it didn't hit the mark. Speaking about this is like so important because the tendency now is like, again, everybody wants the fast fix. The tendency now is like, well, you're having pain with sex. Here, just take this vaginal estrogen, you'll be fine. But like you said,
Yeah.
and it may be a piece that needs to happen,
Yeah.
but it's dismissed. Like, okay, well, you have your vaginal estrogen, move on with your life. And it's like,
Mm-hmm.
but we
No.
haven't considered all the other pieces that I can't have an orgasm, or after I have sex, even with the vaginal estrogen, I still have this terrible heaviness,
Yeah.
you know,
Or
and
sometimes the vaginal estrogen isn't enough. You
yeah,
need lube as well.
right. And what do you do on the days in between? Because vaginal estrogen, is once you do the initial part, it's twice a week.
Yeah. Yeah,
And it's like,
exactly.
okay, the tissue still needs support. And,
Yeah.
and what's the difference between the vaginal lubricants out there?
Well, that's it, and
Mhm.
but even kind of bringing it back to the center of the universe, of course, which is pelvic physio, thinking about, well, if somebody has clitoral phimosis and nobody's actually examined her vulvar tissues to see, what's going on with them, the vaginal estrogen is great, but it's not a magic wand that's going to
Right.
fix everything, particularly if this has been a long-standing issue, as you said.
Hmm.
So she might need some myofascial work. She might need to be taught how to mobilize that clitoral hood. But we actually have lovely evidence from oh Mercier, between 2020 and 2023, she published a couple of different papers looking at how 12 weeks of a multimodal physio approach for GSM was super effective. So that was a combination of manual therapy, pelvic floor muscle training, beyond just squeeze, relax,
Hmm.
but actually down training, creating a sense of elasticity using the vaginal dilators or trainers. Within 12 weeks, they were able to show increased blood flow through the pudendal and the dorsal arteries. Tissue elasticity improved, circulation improved, sexual function improved with just 12 weeks. And that was without any vaginal estrogen. So we can't underestimate, again, this multimodal approach that I know you and I we're kind of on the same page about. And don't be afraid to think with your physio hat beyond vaginal estrogen because, most of us are not prescribers. Our
Hmm.
colleagues in the UK do have the capacity to do a certain amount of prescribing, and vaginal estrogen has become over the counter in the UK. We're hoping that that's going to roll out in the rest of Europe soon. But don't forget, it's about blood flow. There are some tissue mechanics at play here. How can we calm the nervous system down? Well, graded exposure and education are two great tools that are kind of our core skills. And so teaching people the names for their body parts even and
Hmm.
how they work and what's supposed to happen, but this is where you are, but here's the toolbox that we're going to start using to help you help yourself. And it's just about de-escalating the fear and the anxiety that is an absolute destroyer of sexual health for many women.
100%. And the piece that I think that goes along with this blood flow issue that we can help restore in the pelvic area,
Yep.
I want everyone to remember that it's so overlooked. It's like their cardiovascular pump needs to be working too. They
Mm-hmm.
need to be moving
Mm-hmm.
to get perfusion of blood everywhere, right? We need
Yeah,
that arterial
exactly.
oxygenated blood going everywhere. So it's not a matter of just doing bicep curls, it's a
Yeah.
matter of getting that pump going. And any
Yeah.
way that they want to do it, because there's so many ways. And then like you talk about with being the investigator, when are they exercising? Is it an
Mm-hmm.
optimal time for them? Are they trying to exercise when their nose is on the ground?
Yeah,
And maybe they
exactly.
need
Is
to
it
like
is it
switch that up a little bit. Yeah, because now
yeah.
they're getting bloating and distension and they're puffy and exercise isn't doing it for them. It's making them feel worse. And it's
Yeah.
like, is it the time of day? Or what are
Well,
they doing? Are they doing things they hate?
yes, exactly. Are they punishing themselves with exercise?
Yes.
Because, and I really am allergic to this term. Oh, I ate this, so now I have to exercise twice as hard to make up for that. It's
Hmm.
like you didn't kill anybody, it's okay. It's really just empowering, I think, that sense of pleasure seeking
Hmm.
beyond sexual activity, like going outside, feeling the sun on your face, using the good china, buying yourself flowers, getting a
Hmm.
massage, and embracing pleasure in all its forms. So we're really rewiring that brain to look away from pain, disaster, catastrophe to joy and pleasure and happiness. Because, with what you're saying about heart health, I'm going to quote my friend and colleague, Dr. Joe Melios here, who is just, I think, the global leader when it comes to prostatectomy rehab. And Joe would always say, heart health, like HARD, is heart health and vice versa. So sexual dysfunction is often the canary in the coal mine. We acknowledge now in men's health, when they start to have erectile dysfunction, that can be a little flag that maybe their cardiovascular health isn't stellar. But I would say that actually applies to females as well, because those blood vessels, they're teeny weeny, particularly going up towards the clitoris. And so if your orgasms are changing, yes, hormones can be at play here, but let's not forget the vascular and endothelial effects of estrogen. It's a
Mhm.
vasodilator. It promotes arterial flexibility. So if we're taking that out of the mix, we're literally not getting blood supplied through. Okay, so what are we going to do about it? Yes, vaginal estrogen, big fan. However, think about muscle pump, contract,
Right.
relax, contract, relax. So
Mhm.
small pelvic floor muscle exercising within the larger abdominal pelvic region. What's really getting your heart moving, but what makes your brain happy as well. And that together, Debbie Herbenick's done some research around this about exercise-induced orgasms, And even in her studies, the women who didn't end up having an exercise-induced orgasm, they had exercise-induced sexual pleasure. So everyone's a winner when we're exercising with joy. And it's to find out what works for you. But I would say particularly, things like strength training can be so empowering, and things like restorative yoga where you're really, or Pilates even, where you're focusing on breath and that connection, rather than going to a treadmill and watching the news. I mean, there's
Yeah.
no joy. Go out for a walk instead, but be careful about what you're letting into your body in terms of food, obviously, but also like that, there are other types of pollution that we have to be aware of as well. So look for joy, seek out pleasure in any form that you can find, and that's only going to be beneficial from a sexual health perspective, because Mouts did a lovely study, women with vulvodynia who had clitoral self-stimulation and orgasm. They reported that actually still had their vulvodynia, but their anxiety decreased, their
Mhm.
vulvar pain decreased, and this was either by themselves initially or occasionally with a partner. But just to say it's okay to touch and to still experience vulvar pleasure. Don't have to never touch. And because I think a lot of women just get very dissociated once there's
Mhm.
an area of danger down there. So it's about putting people back into their bodies again.
Right. And the art of just being not just intimate with yourself, but you can even be intimate with your partner without having
Yes.
penetration sex. And
Yeah.
I know a lot of work goes around just, can you just hold hands again?
Yeah.
Can you ask your partner to hold your hand? And I think for females especially, it's about learning to be a receiver again
Mm-hmm.
because
Yeah.
we're such givers.
Yeah.
And unfortunately, we become doers,
Tell.
because there's the do and take and there's the give and receive.
Yeah.
And our giving turns into doing.
Mm-hmm.
And so that's where the whole stuff comes in. What about me? What about my time? When am I going to have
Yeah.
it? It's like, this is your time. Let's give it
Yeah.
back to you. Take it
Yeah.
back. Be the receiver for yourself. And do what makes you happy. I love that piece because, again, we know we need consistency. We know we need safety, but it
Mm-hmm.
has to be relevant. And if
Yeah.
they don't find safety and consistency and relevance with what movement they're going to choose to do, they're going to be unhappy because they'll force
Yeah.
themselves to do something miserable, or
Has to be joy.
they're not going to do it.
Yeah. I
And there's
agree.
so many things out there. It's like, do you like to dance? Turn the
Yes.
music on in your house and dance while you do the dishes. That
Exactly.
counts. It's like that counts. And I know a lot of clients, and the clients that I work with still have this mindset that I have to do this for 45 minutes or an hour or it's not going to do me any good. And it's like, you
Have a
know,
snack.
they all are wearing a wearable because that's what I do with my clients because I get their
Yeah.
automatic profile. But it's like, and tell me again why you're counting your steps because
Mm-hmm.
I know I need to have I've decided I wanted to have this many steps in a day. And I said, and why is that? Well,
Mm-hmm.
because that's supposed to help me be better and help my heart rate variability and my movement. And it's like, and do you do all those steps at once? Uh,
Mm-hmm.
It's just kind of like it's a
It's
mindset.
a yeah, it's a reframe, isn't it, of
Yeah,
perspectives. And if I can't do 45 minutes, I might as well not do anything,
right.
So what if we just did 2 minutes? Just 2 minutes of
Mhm.
breathing, I mean, it doesn't get any more basic than that. And like, how can we build mindfulness and ritual and just self-awareness? We talk a lot about proprioception and interoception, but just kind of quieting all of the noise. We all have our phones on the go, and there's all these inputs. What can we do to quiet the noise and kind of come home to ourselves? And making a cup of tea. Just turn that maybe into your little mindful ritual. Or, when you come in and you take off your shoes, have you got a little one of those little massage balls and you can just kind of roll out your feet and getting out of your head and just back into your body again to reconnect with that physical side of yourself, I think can be a great first step without going straight towards the dilators.
Mhm.
Because that can be quite nociceptive and threatening. So it's baby steps. Yeah, absolutely, that's the goal. But this is where we are now. And so
Yeah.
we're just going to, it's like working with a horse. You don't just walk up straight to the horse and talk in your loud voice and here's where we're going to go. We'll throw a saddle on and away we go. You have to kind of just kind of sidle up, nice and slowly, and you talk in a low, slow voice. And, we have some co-regulation of our nervous systems going on. And, we're gauging each other when we're ready to move on to the next step. And I feel like so many of us are in our heads all day, every day. And special shout out to the eldest daughters in healthcare, because
Hmm.
I hear you, I see you, I am you. It's to be able to turn that switch off and kind of, okay, so where am I? How am I really? You know, Instead of
Hmm.
how are you? I'm fine. I'm
Yeah,
fine.
yeah. That's the
Yeah,
cursory cultural answer is what
yeah.
I always call the elevator talk. Hi, how are you today? I'm great, thank you. It's
hmm
like, no,
So
you're,
busy, so busy.
but
Yeah,
how are you?
yeah,
Like,
yeah,
and I know that you're great. That's great too, but how are you feeling? And
yeah.
how did you feel this morning when you woke up? Just changing the questions around can be so empowering for people because they're used to the answers. And our intake forms have those questions in them. How many
Mm,
hours of sleep do you get at night? How many times do you go to the bathroom during the day? Da 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 da. Instead, we're not asking, how do you feel when you wake up in the morning? Because that's a lot more important than how many hours of sleep you're getting at night. When you feel like you have to go to the bathroom, what happens?
yeah,
Like, tell me the story of that versus I go to the bathroom 25 times. Okay, but that doesn't tell me anything.
yeah,
It just tells me that you have a lot of frequency with urination, which could be, by the way, like we're talking about here with everything else, like dyspareunia, there could be a ton of different reasons for that.
yeah.
And newsflash, we have new evidence to show that Michelle just shared on Facebook recently that it's not all about the bladder irritants that we always thought it was. It's about the nervous system.
Which I'm
It's,
sure was music to your ears as well, because that's confirmed what you've been saying for so long too. But
right.
at the end of the day, that's what it's all about, isn't it? It's just about making your brain and your nervous system feel safe and then
Hmm.
also making it happy. And that means letting it sleep, feeding it good things, moving the vessel it's attached to. And I always think like of Mary Oliver poems, and one of my favorite poems is "What are you going to do with your one wild and precious life?" But she talks in a lot of her poetry about just embracing the wild animal of your body, and think about like, if you have a pet cat or a pet dog, when you're stroking them, and it's just pleasure, and sometimes we just need to be able to do that and just kind of, when was the last time you just kind of took a big deep breath all the way down instead of all the way up here?
Hmm.
Like,
A
when
little
was the last
breath
time
that
you,
we
yeah,
take.
when was the last time you actually checked into your pelvis, like during the day? How are you doing down there, pelvis? Are you happy? Rectum, are you empty? Bladder, are you doing okay there? Any dryness there, vulva? Everything good? Are you all comfortable? Am I wearing uncomfortable underwear? You know, like life is too short
I've always
for
said
that.
nothing sets the day worse than wearing the wrong underwear.
It's a disaster.
This
It
is,
is a
and second, right
disaster.
behind it is shoes.
Oh, no, life's too short for uncomfortable shoes. Tools of the patriarchy.
But all of these points are so necessary.
Yeah,
Having these conversations is co-regulating. And like,
yeah,
why do we bring up the story of why do pets make people happy?
yeah.
because we co-regulate right to them.
Exactly.
Have you ever seen a dog not be so excited that you're there?
I
Of course it
know.
makes you happy,
Yeah,
and you
and what muscles
co-regulate.
are they using to wag their tails? They're
Hmm.
using their ischiococcygeus, so their pelvic floors are happy and healthy. So maybe we should
Yeah,
be more like them.
exactly. So, but even plants, caring for
Yeah,
plants is like co-regulation with nature. It's like
yeah,
so all of it so we can co-regulate with our clients.
yeah,
But the trick is working with your clients in a way that's going to help them co-regulate more efficiently for themselves.
absolutely.
Not co-regulating with them in their heightened state, but helping them co-regulate to you and then eventually co-regulate to themselves.
Yeah,
So that they
and
can take
that's
that feeling and it's like, how are you feeling right now about everything? I'm feeling better. Sit there with it for a minute because I want you to take this with you.
yeah,
Because that now their
it's
brain understands
essential.
that I can feel different,
Yeah,
right?
yeah. And I think, it's just one of the most important questions we can ask is, what makes you happy?
Hmm.
And how often are you doing that? And if you're not doing a little something every day that makes you happy, we need to start there before we start talking about manual therapy or mobilizing the clitoral hood or talking about dilators or vibrators. That's really where we need to start. Like,
Hmm.
what can we do just to bring back some happy into your life and just remind your brain what that feels like? Because only a safe brain can be a happy brain.
Hmm.
If the brain is scared, on high alert, there's no time for happiness. Happiness might get you killed. So, what can we do to start reestablishing safety and then happiness? And then let's get back into your body again and let's teach you how to do those skills for yourself.
Exactly. Move them from self-judgment into
Yeah.
self-empathy, compassion, and
Yeah.
then discernment so that they can choose the pathways forward. But when they're upset and afraid and scared,
Yeah.
they cannot see the choices in front of them,
No. And I
right?
think just even explaining why it is different for women, that stress response, that pain response. And you can just kind of see the veils parting, going, oh, that makes so much more sense. When I understand maybe that difference between male and female response to those stimuli, that starts to make much more sense. And then once it makes sense, I'm absolutely allergic to words like compliant and adherent. But it
yeah,
makes ugh, it makes the
it
people that
means
we're working with much more excited about their self-care strategies for the future because they understand the logic and
hmm.
it makes sense. And here's all the evidence I can show you. I can bring up all the research papers and I can show you that this does work. But here's why it works and here's how it's going to work for you. We're going to come up with a tailored approach for you that works with your
Hmm.
life. I'm not going to give you
Hmm.
like 12 different exercises and a 45-minute meditation to do every day because that's not going to work. But what
Mm-mm.
can we do that's going to fit you? What's safe and easy for you to do? And that's where the conversation goes. I'm throwing out questions, but the person, that I'm working with is leading the conversation. And
Hmm.
I'm going to give a shout out to Pete Moore here because he's a self-pain management expert in the UK, a patient advocate. And he talks about how when you're learning to drive, you do start out in the passenger seat and you're watching the instructor and the instructor's telling you what to do. But there does come a time when you actually have to get over and get behind the wheel yourself and start driving the car.
Hmm.
And that's, I think, our job is to get people behind the wheel and to, when you're learning to drive, you're watching mirrors. And, if you're driving a stick shift, you've got clutches and gears and other people on the road. But now we probably can do that, most of us, relatively automatically. And that's what we want to get to. We want to get to that place of automaticity. And that's the way you live your life now. It's full of self-care, it's full of pleasure. And we're really working on addressing those pain drivers because almost every pain driver can be modified if we just find the right path to it. And sometimes it takes a little bit of patience, and sometimes it's not a quick fix. Sometimes it is, though. Like if it's just a
Hmm.
question of lube or sexual ergonomics, that's brilliant. Like you can have somebody going from 0 to 60 super fast,
Hmm.
in terms of recovery. But sometimes there's a bit more, a few more layers to work through. But if you can get a couple of quick wins, that really gets great buy-in and strengthens that therapeutic alliance that we all talk about.
Hmm. And the best way to do that is to be curious
Yes, and
Be
non-judgmental.
open-ended.
Yeah.
Do not be judgmental. I love the idea about the car, and I've heard him t tell this story many times.
Yeah.
And one of the things that I always add to that is if you're the driver of the car and they're sitting next to you, what are you modeling to them? That you're in control and you're taking it all over? Or are you demonstrating and discussing and sharing
Yeah. I might be holding
for
the map,
them in a
but
way that they can take it all in,
Yeah.
right?
Yeah,
Maybe you don't need
exactly.
to be driving, maybe you just need to be sitting in the car together before you
Yeah.
ever put the key in the ignition,
Just listen to some
right?
music.
Exactly. And so when, really getting clients to co-regulate and to come down a little bit, and you talk about simple things, and one of the things I always
Yeah.
talk about is turn the music on.
Uh-huh.
Bonus if they choose it, because
Oh,
we have
100%.
we
Yeah.
have real research that shows two new things now. Number one, pain de-escalates when we listen to music. It
Mm,
does, because it's another part of our brain that's
yeah.
going. And so, of course, we're getting the cross midline, but with another sensory input through the auditory. But bonus points if they get to choose their music. They do even
Mm,
better. There's also real evidence that it will calm that anxious activity as well. So they've done studies with people in a waiting room going to see a physician, and some listen to, whatever talk show was on, others listen to music, others listen to nothing. By far, the people who went into the room when they were called were just had such a better response. They could hear,
amazing.
they could pay attention, they could recite what their plan was way better than the other two.
I love
It
it.
was like just crazy stuff. And so now they're actually looking at that, using that kind of thing before sleep. Is it,
Mm,
can that if it calms the nervous system here and it calms the nervous system here, maybe for the people who don't like sleep meditations and don't like the other things, could
yeah.
just sometime in the evening, before bed, for an hour before bed, is like maybe just listen to something that you love.
Yeah.
Whether
Yeah.
it's musical poetry or it's like music itself, or maybe people really like those different healing vibes,
Yeah.
528 hertz or 428 hertz, or those things as well. So,
Exactly.
Michelle, before we end this amazing time together, what is the top thing? Like, if you had to say one thing, if you walk away from this talk from Susan and Michelle, what's the one thing you want people to just walk away with? I know there's many, but
There's I'm trying to be selective here. Um, I would say if you are talking to somebody about their sexual health, and of course we want everybody to talk to all our clients about sexual health, don't ask if they're using lube, ask which lube they're using. Because that really normalizes, I think, the concept of using lube, which is so underrated and so embarrassing for some people because if they can't produce enough lubrication themselves, for some people that's a really big stigmatizing event. So I just, and which lube are you using? And then I have samples and do you like oil-based or silicone or water-based? What do you find yourself going for most? And so it just really becomes this normalized thing of, oh, I should be using lube. I'm like, oh yeah, here, try this. Always do a patch test on the forearm first. But absolutely. And don't use a silicone lube if you're using a silicone toy, and don't use oil-based if you're using condoms. But let's just normalize that conversation. Because I think I managed, did you see there? I managed to sneak about four different questions in there. That for
Mhm.
me is so I apologize, but that for me is a big thing that we can do because, most of us have access to these samples and we can just, we can say, and you can go to your health food shop, you can go to your pharmacy. It's so widely available. Don't try that one because that can be quite irritating. Stay away from anything that sparkles or has glitter or changes temperature. Maybe don't vajazzle, just be kind to your vulva. But these are some of the ones that a lot of the people that I work with really like. Try them and then come back and let me know how you get on. And that just kind of just lowers the tension around it straight away because now they know it's a safe space to have these conversations, that I'm not going to be embarrassed about it because this is what I do all day, every day. So they certainly shouldn't be embarrassed about it because they're coming to see me with all these questions. And now safety has been established. And you
Right.
can just kind of see the nervous system going, oh, oh, okay. So now that
It
we've talked
moves,
about
it
lube, can
moves
I
them.
also ask you, and it opens up all the doors.
Yeah, well, and it basically what it does is it takes the yes or no or the like decision type answers away and
Mm-hmm.
puts choices in front of them right
Mm-hmm.
away. So they're empowered to choose.
Yeah,
I can choose a lubricant. Maybe I'm not made. Should I be using one? Right? Like choices instead of
absolutely.
no, I don't. Yes, I
Yeah,
do. Like there's
yeah.
such a difference in that. Just that simple statement. And that's curiosity at its best. Final question for you.
I'm so
What are
nervous
you
about these questions.
what are you reading right now?
What am I reading right now? Oh, I am reading Alive, an Alternative Anatomy. And it's kind of looking at the socio-cultural aspects of different body parts. So I'm on the chapter about the uterus now. And he had me, I feel like, what's that film? Is it Jerry Maguire where you had me at hello?
Mhm.
I
Yeah.
flipped open this book in a bookshop and I just by chance, or did I, open it to the uterus chapter. And he starts out by talking about how, lots of people say that the brain is the most important organ or the heart, but for me it's the uterus because without the uterus, none of us would be here. And then it
That's
kind of goes on
absolutely
from there.
true.
So love it. It goes hearts, lungs, brains, uterus. But I'm really enjoying it so far. Just a different perspective on how culture can influence our anatomical perspectives.
100%. Thank you for your time. Thank you for your
Pleasure.
generosity. Thank you for all you do for everybody in
Ah,
this sphere. And thank you for pushing the envelope out there to others to remove the stigma, to improve the conversations, and to invite even our medical colleagues in to the conversation a little bit more. We're all the better for it. Thank you so much.
thanks, Susan. Appreciate that.